Gastroesophageal reflux disease, or GERD, is a common condition where stomach contents flow back into the esophagus, causing symptoms like heartburn and regurgitation. This backflow can lead to discomfort and, if left untreated, may result in more serious complications. GERD is a multifactorial disease, meaning it can have many causes and a wide range of symptoms. Some people experience classic symptoms, while others may have less obvious signs, such as cough, laryngitis, or even dental problems. As technology and screening methods have improved, more cases of GERD are being diagnosed, making it a significant health concern worldwide. GERD affects millions globally, but its prevalence varies by region. In the Western world, about 10 to 20% of people are affected, while in Asia, the rate is less than 5%. These numbers highlight the importance of understanding cultural and lifestyle factors that may influence the development of GERD. Interestingly, not all patients with GERD experience the classic symptoms of heartburn or regurgitation. Some may have silent reflux, especially older adults, who might only present with complications after years of unnoticed disease. This makes awareness and early diagnosis crucial. The symptoms of GERD can be quite diverse. While heartburn and acid regurgitation are the most recognized, patients may also report chest pain, difficulty swallowing, sore throat, or even respiratory issues like asthma. Some people may not notice any symptoms at all, which is particularly common in older adults. In these cases, GERD might only be discovered after complications arise, such as esophagitis or even esophageal cancer. Recognizing the broad spectrum of GERD symptoms is key to timely diagnosis and management. If GERD is left untreated, it can lead to several complications. Chronic exposure of the esophagus to stomach acid can cause inflammation, known as esophagitis, and may result in strictures or narrowing of the esophagus. In some cases, the lining of the esophagus changes, a condition called Barrett's esophagus, which increases the risk of esophageal cancer. Other complications include aspiration pneumonia and dental erosion. Early recognition and management of GERD are essential to prevent these serious outcomes. The main cause of GERD is the failure of the anti-reflux barrier at the gastroesophageal junction. This allows acidic stomach contents to flow back into the esophagus. Three key mechanisms are involved: transient lower esophageal sphincter relaxations, a weak or hypotensive lower esophageal sphincter, and anatomical disruptions such as hiatal hernia. Other contributing factors include delayed gastric emptying and poor esophageal clearance. Understanding these mechanisms helps guide effective treatment strategies. Diagnosis of GERD often starts with a clinical assessment based on symptoms like heartburn and regurgitation. However, not all patients present with typical symptoms, so further testing may be necessary. Diagnostic tools include upper endoscopy, barium swallow, esophageal manometry, and 2-4-hour pH monitoring. These tests help confirm GERD, rule out other conditions, and guide treatment decisions, especially before considering surgical options. Upper endoscopy is a key diagnostic tool for GERD. It allows direct visualization of the esophagus and stomach, helping to identify inflammation, erosions, or changes in the tissue lining. Biopsies can be taken during the procedure to check for Barrett's esophagus or rule out cancer. Notably, some patients with GERD may have a normal endoscopy, especially those with non-erosive reflux disease. Despite this, endoscopy remains essential for evaluating patients with alarm symptoms or those considering surgery. The barium swallow test is another valuable diagnostic tool for GERD. During this test, the patient drinks a barium-containing liquid which coats the esophagus and stomach, making them visible on X-rays. This helps doctors identify anatomical abnormalities like hiatal hernias, strictures, or motility disorders. The test can also show reflux of contrast material, but it does not always correlate with symptoms. Barium swallow is especially useful in surgical planning and in patients with swallowing difficulties. Esophageal manometry measures the pressure and movement of the esophagus and the lower esophageal sphincter. This test is crucial for assessing esophageal motility and determining if the sphincter is functioning properly. In GERD patients, manometry can reveal whether the LES is weak or if there are abnormal muscle contractions. The results can influence the choice of surgical procedure, as certain types of fundoplication are better suited for patients with weak esophageal muscles. 24-hour esophageal pH monitoring is used to objectively measure acid exposure in the esophagus. A small probe is placed in the esophagus to record acid levels over a full day. This test is particularly helpful for patients with atypical symptoms or those who do not respond to standard treatments. An abnormal pH test, especially in patients dependent on proton pump inhibitors, can predict successful outcomes with anti-reflux surgery. The first step in managing GERD often involves lifestyle changes. Patients are encouraged to lose weight, stop smoking, eat smaller meals, and reduce alcohol intake. Elevating the head of the bed and avoiding meals close to bedtime can also help. Among these, weight loss and head of bed elevation have the strongest evidence for improving GERD symptoms and reducing acid exposure. These simple changes can make a significant difference for many patients. When lifestyle changes are not enough, medical therapy is the next step. Antacids provide quick relief for mild symptoms, but are not suitable for long-term use. Proton pump inhibitors, or PPIs, are the mainstay of medical treatment, effectively reducing stomach acid and relieving symptoms for most patients. However, some people may not respond to PPIs, and long-term use can have side effects such as bone loss or increased infection risk. In these cases, further evaluation and alternative treatments may be necessary. Surgical treatment is considered for GERD patients who do not respond to medical therapy, cannot tolerate medications, or develop complications like strictures or Barrett's esophagus. Surgery is also an option for those who prefer not to take lifelong medications. The decision to proceed with surgery is made after thorough evaluation and discussion between the patient and the surgical team, considering individual anatomy and preferences. Endoscopic procedures have been developed as less invasive alternatives to surgery for GERD. These include techniques like radiofrequency ablation of the lower esophageal sphincter, stretta procedure, and endoscopic suturing to recreate the angle between the esophagus and stomach. While promising, these treatments are still considered investigational due to limited long-term data on their effectiveness and safety. They are not recommended as first-line therapy for patients with severe symptoms or complications. Transoral incisionless fundoplication, or TIF, is an endoscopic procedure that aims to recreate the anti-reflux barrier without external incisions. Using specialized devices, the surgeon creates a partial wrap at the gastroesophageal junction. While TIF can reduce symptoms in selected patients, it is still considered investigational, and long-term results are not as well established as traditional surgical options. Among surgical options, laparoscopic fundoplication remains the gold standard for treating GERD. This procedure involves wrapping the upper part of the stomach around the lower esophagus to strengthen the anti-reflux barrier. The choice of surgical technique depends on several factors, including the patient's anatomy, esophageal motility, and the presence of complications like hiatal hernia. The most common types are Nissen complete and Toupette or Door partial fundoplications. Nissen fundoplication is the most widely performed surgical procedure for GERD. It involves a 360-degree wrap of the stomach's fundus around the lower esophagus, creating a strong barrier against reflux. The operation is typically done laparoscopically, resulting in less pain and faster recovery compared to open surgery. Nissen fundoplication is highly effective in relieving symptoms and reducing the need for medications, but it may cause side effects like difficulty swallowing or gas bloating in some patients. Two-ped fundoplication is a partial 270-degree posterior wrap of the stomach around the esophagus. This technique is often chosen for patients with weak esophageal motility, as it reduces the risk of post-operative swallowing difficulties. Studies have shown that two-ped fundoplication is as effective as Nissen in controlling reflux, but with fewer side effects like dysphagia and gas-related symptoms. Door fundoplication is another partial wrap, involving a 180-degree anterior wrap of the stomach around the esophagus. It is less commonly performed than Nissen or two-ped, but may be considered in select cases, such as after certain esophageal surgeries. Door fundoplication can effectively control reflux and is associated with a lower risk of postoperative dysphagia, but may have a higher rate of reflux recurrence compared to complete wraps. The Belsey Mark IV operation is a transthoracic partial fundoplication, performed through the chest rather than the abdomen. It is mainly reserved for patients with a hostile abdomen due to previous surgeries or those who have failed multiple abdominal procedures. The Belsey procedure creates a 270-degree wrap and is less commonly used today due to advances in laparoscopic techniques. Hill gastropexy is a surgical technique that involves anchoring the stomach to the diaphragm to reinforce the lower esophageal sphincter. This procedure is sometimes chosen for patients with a small stomach due to previous surgeries. Hill gastropexy can be performed open or laparoscopically and has shown good short and long-term outcomes in selected patients. Magnetic sphincter augmentation, known as the Lynx procedure, uses a ring of magnetic beads to reinforce the lower esophageal sphincter. The device allows food to pass during swallowing but prevents acid reflux. Lynx is less invasive than traditional fundoplication and is associated with fewer gas-related symptoms. However, it is not suitable for patients with large hiatal hernias or allergies to certain metals. Long-term data on safety and efficacy are still being collected. When comparing surgical options, both Nissen and two-ped fundoplications are effective in controlling reflux. Nissen offers a more robust barrier, but may cause more side effects like bloating or difficulty swallowing. Two-ped, being a partial wrap, is associated with fewer side effects, but may be less effective in some cases. The choice depends on individual patient factors, including esophageal motility and previous surgeries. Obesity is a well-known risk factor for GERD. In morbidly obese patients, traditional fundoplication may not be as effective. Instead, Roux-en-Y gastric bypass is often recommended, as it not only helps with weight loss, but also significantly reduces reflux symptoms. Some studies have even shown regression of Barrett's esophagus after gastric bypass in obese patients. However, this approach is still debated among experts. Choosing the right surgical procedure for GERD involves a shared decision-making process between the patient and surgeon. Factors considered include the patient's anatomy, degree of esophageal shortening, motility disorders, and previous operations. The goal is to select the most effective and safest option tailored to the individual's needs and preferences. The Nissen fundoplication procedure involves several key steps. First, trocars are inserted to provide access for laparoscopic instruments. The liver is gently lifted to expose the esophagus and stomach. Any hiatal hernia is reduced, and the short gastric vessels are divided for better mobilization. The esophagus is carefully dissected to ensure enough length is available for the wrap. The crura of the diaphragm are closed, and the fundus of the stomach is wrapped 360 degrees around the lower esophagus and secured with sutures. A common modification of the Nissen fundoplication is the Rossetti-Nissen technique, which involves a 360-degree wrap without dividing the short gastric vessels. This approach is less common in the United States, where most surgeons prefer to divide these vessels for better mobilization and to reduce tension on the wrap. The choice between standard and modified techniques depends on surgeon preference and patient anatomy. Partial fundoplication procedures are designed for patients with weak esophageal motility or those at risk for postoperative swallowing difficulties. The two most common types are TUPET, 270-degree posterior wrap, and DOR, 180-degree anterior wrap. These procedures offer effective reflux control with a lower risk of side effects compared to complete wraps, making them suitable for select patient populations. Long-term studies have shown that laparoscopic Nissen fundoplication is highly effective in preventing reflux recurrence and reducing the need for medications. However, some patients may experience side effects like bloating or difficulty swallowing. Partial fundoplications, such as TUPET and DOR, offer similar reflux control with fewer side effects, but may have a slightly higher risk of recurrent symptoms. The choice of procedure should be individualized based on patient characteristics and preferences. After fundoplication surgery, most patients experience significant relief from GERD symptoms and improved quality of life. However, some may develop side effects such as difficulty swallowing, gas bloating, or inability to belch. These issues are generally less common with partial fundoplications. Regular follow-up is important to monitor for complications and ensure long-term success. While fundoplication is generally durable, some patients may experience recurrence of reflux symptoms or require reoperation. Factors contributing to recurrence include anatomical changes, breakdown of the wrap, or progression of underlying disease. Partial wraps may have a slightly higher recurrence rate, but overall, most patients enjoy long-term relief. Early recognition and management of recurrence are important for maintaining quality of life. Patient satisfaction after anti-reflux surgery is generally high, especially when the procedure is tailored to individual needs. Most patients report significant improvement in symptoms and quality of life. Open communication between patients and their healthcare team is key to setting realistic expectations and achieving the best possible outcomes. The field of anti-reflux treatment continues to evolve, with ongoing research into new surgical techniques, endoscopic procedures, and medical therapies. Advances in technology and a better understanding of GERD pathophysiology are likely to improve outcomes and expand treatment options. Personalized medicine, where therapy is tailored to each patient's unique characteristics, is becoming increasingly important in GERD management. Fundoplication is a surgical technique designed to reinforce the lower esophageal sphincter and prevent acid reflux. The procedure involves wrapping the upper part of the stomach around the lower esophagus, creating a new, stronger barrier. There are several types of fundoplication, including complete and partial TUPET, DOR, each with its own indications and benefits. Understanding the concept of fundoplication is central to modern GERD treatment. The lower esophageal sphincter, or LES, is a ring of muscle at the junction of the esophagus and stomach. Its primary function is to prevent stomach contents from flowing back into the esophagus. In GERD, the LES may be weak or relax inappropriately, allowing acid reflux. Strengthening or augmenting the LES is the main goal of both surgical and endoscopic anti-reflux treatments. A hiatal hernia occurs when part of the stomach pushes up through the diaphragm into the chest cavity. This anatomical change can weaken the anti-reflux barrier and contribute to GERD. Hiatal hernias are often repaired during anti-reflux surgery to restore normal anatomy and improve surgical outcomes. Barrett's esophagus is a condition where the lining of the esophagus changes due to chronic acid exposure from GERD. This change increases the risk of developing esophageal cancer. Detecting and monitoring Barrett's esophagus is important in GERD management, and surgical treatment may help reduce progression in some cases. Proton pump inhibitors, or PPIs, are medications that reduce stomach acid production. They are the most effective medical therapy for GERD and are often used as first-line treatment. While generally safe, long-term use of PPIs can have side effects, so ongoing evaluation is important for patients on chronic therapy. Esophageal manometry is a diagnostic test that measures the pressure and movement of the esophagus and lower esophageal sphincter. It helps identify motility disorders and guides the choice of surgical procedure for GERD. Manometry is especially important in patients with atypical symptoms or those being considered for partial fundoplication. The Stretta procedure is an endoscopic treatment for GERD that uses radiofrequency energy to strengthen the lower esophageal sphincter. It is less invasive than surgery and can be performed on an outpatient basis. While promising, the long-term effectiveness of the Stretta procedure is still under investigation. The LINX device is a magnetic sphincter augmentation system used to treat GERD. It consists of a ring of magnetic beads placed around the lower esophageal sphincter, allowing food to pass while preventing reflux. The LINX device is an alternative to traditional fundoplication, especially for patients who want a less invasive option. Roux-en-Y gastric bypass is a surgical procedure primarily used for weight loss, but it is also effective in treating GERD in morbidly obese patients. The surgery reduces stomach size and reroutes the digestive tract, significantly decreasing acid reflux. It is especially beneficial for patients who have not responded to other treatments. Esophageal motility disorders refer to abnormal muscle contractions in the esophagus that can affect swallowing and increase the risk of reflux. Identifying these disorders is important before surgery, as they influence the choice of fundoplication technique. Patients with weak motility often benefit from partial rather than complete wraps. Shared decision-making is a collaborative process where patients and healthcare providers work together to choose the best treatment option. This approach considers the patient's preferences, values, and unique medical situation, ensuring that the chosen therapy aligns with their goals and lifestyle. In summary, GERD is a common and complex condition with a variety of treatment options. From lifestyle changes and medications to advanced surgical and endoscopic procedures, therapy is tailored to each patient's needs. Fundoplication remains the gold standard for surgical management, with several variations available. Ongoing research and a personalized approach are key to achieving the best outcomes for patients with GERD.